So this month we have talked a lot about the IRB and research in general. Last week, I think the first of the month, we had Jonathan Miller present. The second Thursday of the month, we had a session in here where we just practiced consenting. And that was really kind of fun. It was just a hands-on. Today, the focus is going to be on including children in research. We're going to kind of be in two parts here. Barry Cotton's going to be doing this with me. But I'm going to start by really just looking at the regulations, kind of the dry part. Barry works a lot in pediatrics and is going to kind of share some of the experiences she's had and maybe give you some insights on how to best consent children and families into studies. So again, this is going to be a bit dry. I'm really going to be pointing out a lot of the regulations as we go through, because they are important. And I think as I was going through the presentation, I thought, you know, as coordinators, as researchers, we often think the regulations are something we need to know for ourselves. And that's true. But we need to know them so that we can justify how we're conducting research to our study subjects. And I'll explain that as we go through. So there are things in here that when you go to, for example, when you go to consent a family and you're trying to explain the risks, you really need to understand what the risk levels mean so that you can tell those parents, okay, you know, no greater than minimal risk. What does that mean? Parents need to know that. So again, you often don't think of the regulations needing to be directly presented to families, but you have to understand what's behind your research to better inform and help families understand trials. Because with children and really any vulnerable population, we have to be very careful. Those are the folks who need, you know, that extra bit of an explanation. And as you know, parents are going to be 10 times more protective of entering a child into a research study than you would if you were going to do a research study, or I would. So primarily today, I'm going to talk about and define what and who is a vulnerable population, or who is vulnerable. And again, if children fall into that, I'll do a superficial review of all the other vulnerable populations. How to deal with the vulnerable populations, and then I identify issues related to consenting. Again, if you look at the regulations, these are all the people who we consider, or all the groups that we consider to be vulnerable. I am not going to spend time talking about the elderly, cognitively impaired prisoners, or the economically impaired. But I think it's important to know that these are the groups that really require extra care, extra attention, and they'll get your attention and the IRB's attention, and certainly the federal government, if you have an IND, they'll pay attention to these issues as well. So let's just overview talking about children and really any vulnerable population. Why is it an issue? Do they have the ability to comprehend consent and consent into the study? Again, if you look at these, every one of these may have challenges with that. There's increased risk, possibly. The ability to freely consent. Any of those vulnerable populations would have great challenges in consenting, and children are not apart from that. And children easily coerced and manipulated, and I think we've all seen that. We see it all the time. We had a study that we were doing in the ED. It was in one of the clinics. It wasn't the emergency department. And it was really just a natural history kind of study where we were enrolling healthy children and we were just collecting, we actually wanted some blood and then they had to send us a little bit of poop. You know, they took the card home and sent it to us for a hemoccult testing. But there was money involved. And it was pretty apparent the parents were there just before school started to get money. So, and I'll talk a little bit more about that. But again, it's hard to compensate and not coerce children sometimes. So again, all of that has to be carefully weighed. There are multiple regulatory authorities who oversee research, and as you know, this is just a review. You've got DHHS, which includes FDA and OHARP. One of the key elements that we all hear about often is the common rule. So I put this slide together so you see it once again. Often we get confused confused about what the common rule is, or if you don't hear it, you don't know what it is. But it is the policies that we use for protecting human subjects. And it applies to many things, even things outside of research. But again, I'm not going to read through this. Some of these slides will simply be resources for you. Again, these are additional protections. All of the common rule is put in place to really protect our human subjects who participate in research. Oops. OHARP, it's under DHHS. As you know, OHARP is over the IRBs. Again, they have, again, I just want to present this so we know all the players in our pool. Again, things you may know, but it never hurts to have these refreshed. IRB membership, again, we're looking at vulnerable populations. So the IRBs are dictated and required, especially if they're accredited. And if they have federal-wide assurances, then they will abide by this. And they have to have members on the board who could appropriately review the protocols, which means they have to have knowledge of those vulnerable populations. So I'm going to, the breadth of talking about children, I'm going to expand it beyond that just to fetuses, because that's sort of early children and pregnant women are involved in this too. So certainly fetuses and human in vitro fertilization is clearly part of children, and they are a vulnerable population because they are so intrinsically related to their mothers that, and they cannot consent for themselves. So there's been many debates, and there's a bit of history here about how we've come up with what is required when we do research with fetuses. I present that simply to say there's a great deal of oversight. Fetuses are indirect subjects, so they require extra protections. Again, the history being in 1974, not too, certainly around the time of Tuskegee, we were also looking at this population. And the National Commission was put together, and they focused heavily on fetuses as well as other issues related to children. I thought it was interesting that, one of the most important things to remember here is that risk to the fetus from any research procedure must not be more than minimal risk. One of the things you have should be a list of definitions. Did you all get a copy of that? And I think that's a really helpful tool. I think I don't have mine with me, but it's critical to know that not more than minimal risk is rather like when you wouldn't be exposed to a risk that is any greater than what would happen on a day-to-day basis. So if you're a sick child and you have cancer and that child goes to the hospital, the doctor frequently, their normal level of risk might be a bit higher. So again, if you're a healthy child, that normal level of risk is going to be different. Again, I do think in dealing with children, our IRB is our greatest asset because they help us interpret what's critical and what's not. So these are some considerations that the IRB might look at. If you're taking on a study and you're preparing your IRB application, you need to be thinking about these things. IRBs they're required to see if there was a research with animals prior to going into subjects. Again, there are always exceptions. Please know that anything that is said, these are guidelines that folks must follow. If feasible, you always want research in non-pregnant women. You want research in healthy people. The ideal is to have tested whatever you're testing to the hilt in people who are not vulnerable. Sometimes you end up going to the vulnerable population early. Again, we think about our cancer studies. Sometimes we don't wait around for the lots of studies having been done on healthy people and older people. If it's a childhood disease and it's a phase 1, or it's a high-risk cancer, they may go directly to children. There's also, just of interest and something to be aware of, if abortion is involved, there's no way that abortion can have any relationship to the research study. It just has to have been done for some other reason, and then you, after the fact, would be aware of it. Any involvement before that is totally prohibited. There is certainly an advisory board with the DHHS, and if there's funding to be had for in vitro fertilization, the ethics advisory board will roughly review the protocol as well. Fetuses in humans, other IRB considerations. Again, research is directed toward the fetus in utero. It can be there can be an indirect benefit to the the fetus. It can be a direct benefit, or it can be to the mother as well, or it can be to both. Sometimes there's research, if you think about it, with a mother who's in crisis in pregnancy. There may be risks that might occur to the fetus that are going to help save the mother's life. I mean, there are, as you know, there's so many factors that have to be considered when we're getting into these sorts of studies. The IRB may approve research directed toward the fetus in utero if it is to meet the needs of the fetus, and they're conducted in a way that will minimize, risk. And it's also, it is requested that it be no more than minimal risk. So again, we're trying to be as protective as we can of this population. There have been regulations put in place for fetal tissue transplant. Again, if you are, as you can see, we've extensively looked at this. One of the keys is not to overextend what we're doing and to make sure that we protect the subject and the person receiving the possibly the transplant. Again, this is reiterated, separating abortion from the research. There's also prohibiting payments and other inducements. Payments, they must be very commensurate. I mean, again, a lot of these things you're seeing and hearing are not unlike what we do for other people. This is somewhat repetitious, so I'm not going to read this again. But it's very, very important to adhere to what is expected in research with the fetuses and abortion. Fetal tissue transplantation, again, what you've got there is a great deal of the challenge of harming a tissue that could have been viable. And so the issue is not to make sure that it's clearly used in a manner that is appropriate and will not cause any more harm than is necessary. I'm going to skip this slide on abortion because I don't think we will actually be doing any of those. Consent for, this is a critical piece, consent for research on the fetus. Consent from others required, and consent for the father is also generally required. Now, keep in mind, some of these will be applicable to children. The reason we want to consent the father is he's the father. He is, partly responsible for that child. He also, if there are medical bills, once that fetus is born, and the medical bills are a result of the research, he will be responsible for those bills, possibly. And again, involving a fetus in research in cases where the parents are not in agreement is really quite a challenge. That can be destructive to a family. So there will often be a situation where the father is required to co-sign the consent form with the mother. There are exceptions, of course. If the pregnancy was a product of rape, the father is not reasonably available, and again, that's a term which will be difficult to define, but it's an important one to address. The father's identity or whereabouts cannot be found. Again, additional information on what is reasonably available. Again, it's a broad, very vague statement. Paternity is uncertain, father's whereabouts, again, we've already stated that. The father does not acknowledge that he is the father of the fetus. The father has assumed no responsibility for the pregnancy. Again, you walk a fine line when you have to address some of these, but it's important for you to be aware of them. If you have any issues or concerns about whether you need that father's signature or whether you have addressed these appropriately, I'm going to tell you, and we've got several IRB folks here, I would call the IRB. These are big decisions to make on your own if you're going to be excluding a father. If you just have a question, they're willing to talk through it with you. That's very important. Research, and again, continuing with the vitro fertilization. There's been lots of reviews. And again, I just really shared this slide to show you that there are many people involved in setting up our standards. And those have sort of led to what we would consider points to be considered when including fetuses in studies. This is a laundry list of 8 items that the IRB will probably look at, but if you're designing studies, you should think about these things. and know, and as you're, if you think about it, when you also with families, when you're consenting them, you can share that with the families that all of these things have been addressed. That we have looked closely at, who's going to be consenting and why. You can explain that to families. What is the risk level? Why is, what happened in animals? These are things that you critically need to know to share with families. So research in children, again, probable risks. That's the one thing we look closely at. Are all of you familiar with the UAB Special Population Form for Children? I will probably from the next one. But if you look at these 4 things, that's what's on the risk form for children. Again, we address every one of these points is addressed on that form. And as you know, when you do research with children, you have to identify what their risk level is. You have to identify if it's 1, 2, 3, or 4, and these numbers correspond with our special population checklist. So you've got certainly research not involving, and I have highlighted what's critical here. So the first level is not involving greater than minimal risk. Nothing more than what happened when you walk to school in the morning. Research involved, the second level is research involving greater than minimal risk, but possibly a benefit to that child. Another is greater than minimal risk, but no prospective benefit to the individual, but maybe will help with the generalizable knowledge. There could be a minor increase over minimal risk, but you don't want it more than that. So see, we've got greater than minimal risk, but it's always going to be a minor. It's not going to be a great deal over the minimal risk. It's still going to be low, especially when there's no benefit. And last of all, this is one I have never seen, because I believe this is the one that ends up having to go to the secretary for consultation on. Have you all had to deal with one like this?
I've never seen one. It's been 10 years and I've never seen one.
We try not to. I would hope so. I think that would definitely be
It's like children's hospital, specifically children's hospitals, and really, I don't mean like our children's. Maybe they do that at St. Jude's. I don't know.
Yes.
But
yeah.
I've never seen that.
But that would be so. It is on your form, but you will hopefully never use it. I just can't imagine the paperwork that would be associated with this.
And the wait. You should have to wait for the secretary to convene that panel and go through all that. So
you're looking at a year or 2 down the road.
Mm-hmm.
So again, this is a restatement of what minimal risk is, and I think this is language we all need to have really readily available to us. Again, no more than minimal risk to a healthy child. Again, things that don't happen more often than what would occur in daily life. And again, as I said earlier, that also is dependent on the disease. You have cystic fibrosis, your normal life is quite different than, again, a healthy child. In assessing the benefits, the IRB will consider a variety of, again, the health statuses of the potential subjects and what's going to benefit them. And you'll need to look at that too, because you're going to be explaining to the parents what the benefit might be to their child if there is one, or if there's not a benefit. I mentioned earlier about the phase 1 studies, and this is true for adults. Phase 1 studies often don't have as extensive animal testing, possibly, or other prior human testing, so first time in humans. We try our very best not to give any drug to children that has not been fully tested in any human, in any adult, or in adults. And but sometimes, as I said, depending on the condition, they might go right to phase 1 in children, as we do with cancer studies. Consent procedures, we certainly have assent. This is a critical component to working with children. People often ask, what is the age of assent? And it's on the protocol. There is not a hard and fast rule. I've often heard people say 12, sometimes it can be 7. Your IRB, you will tell your IRB what and how you're going to, what the population is. You'll provide for them the information about the study, the disease, and what the procedures are. And then the IRB will probably give you good guidance on what is the age of consent and whether you need it. Again, the things that are considered for assent are age, maturity, and psychological status. We had as I was mentioning earlier, there was a study we were doing with healthy subjects, and the children were going to get paid. This is probably more than it was, but they would get a total of $100, $50 for the visit. They'd come in, consent, and drop away. A few questions. They'd take a kid home, and they'd send stool in 3 weeks later. Then they get another check in the mail for 50. All of that is well and good, except after the child signed the assent and they realized they were going to have blood drawn, they started screaming. Made the determination that was a statement of withdrawal of assent, because they may have signed it, but needles are pretty frightening things, and it may have sounded good, and the money may have sounded great, but again, withdrawal of assent is something that you have to consider all the time. Parents often have an impact on assent, and that's the challenge, I think, for doing research with parents and children. Parents may want very badly for their child to be in a study. Could be for money, could be for simply what the parent perceives as a benefit. And there is a point, if you have a protocol that requires a child assent and you have a major issue with the parent, again, you are concerned about the situation, and I would call the IRB just to get back up, because sometimes you feel you're all alone out there when you're trying to deal with these issues. And I hope the IRB will come in and please, because I feel like the IRB is there to help us and support us. And when we have these challenging ethical issues, they're the folks that we need to contact.
One of the things, excuse me, but one of the things that we struggle with, and that we know investigators and people on the in the leads struggle with, is if you say you're going to get assent, then you've got to honor that assent. If the child says no, I don't want to do it, you've got to not do it. Right. And so it really does get dicey, and we are there to have conversations about whether or not it's appropriate and how to rate it if it's not.
Mm-hmm. That's good. So consider them as a very strong resource. If the child's capable of assent, it can be waived. It can be waived for various reasons, and here are some of them: minimal risk, probably all of them together. We wouldn't just pick one; it would be all 4 of them. Minimal risk, assent is not practical, waiver will not adversely affect the rights and welfare of the child, and which is kind of applicable for even our adult studies. Pertinent information will be provided after the research. Again, in an emergency situation, you often do the procedures or start the study before you do that. Get the consent because of the emergency part of the research. So again, I mentioned earlier, what's the age of assent? This is actually, I stole this from the IRB guidelines. So this is how they've described it. When younger than 7, obtaining assent may be appropriate, depending upon the participant population. And probably already also the protocol. Again, if it's not obtainable, a written assent document may also be appropriate. 7 or older, but younger than 14, assent may be obtained unless this requirement is waived by the IRB also. Again, it's nice to know we're consistent. Again, every situation is different, so it's hard. I cannot say it's really hard to really about this. 14 but younger than 19, it's almost you're more likely to have. The older the child gets, the harder it's going to be to get a waiver of assent. Excuse me. But even through the age of 18, we will need assent. I think one of the challenges that Barry and I were discussing earlier is you're doing a study on a newborn child, the parents can be 17 and they can consent for that. But if that 17-year-old comes, the very same child, 17-year-old, comes in for a research study not related to the baby, the parent has to be there. So it feels a little bit backwards, but we kind of, is that part of the Alabama state law as well? Mm-hmm. Okay. The laws are following the research now. So we have to, yes. consent.
It's useful to point out, though, that parental permission requirement can also be waived by the IRB.
So in that situation, depending on the type of study, if you're doing an STD study, possibly in a 17-year-old, you may get that. Some sort of drug study or something like that, where it's to protect the rights of the child.
But we have to talk about it.
That's right, yes, again, it's an option, but one that will be thoroughly vetted before it's provided.
And what we look at is that how you're justifying that request for the waiver, because many times that 17-year-old mother doesn't let it come and her parents are not available. And in these situations, we do waive parental consent for that 17-year-old mother because the parents aren't available.
Good.
She's in the town to her boyfriend or friends.
So when it comes to the consent procedures, again, how you go about it is something you'll also explain to the IRB, how you're going to consent the child. But you need to be presenting it in the language that they'll understand, not unlike our adults. You'll always need to consider their age, their experience, maturity, and the condition, their disease condition. As with adults, our cancer patients know a whole lot more about their disease than someone who comes in with a newly diagnosed arthritis, say. So for children, a child who has a chronic illness and they're 13, they're really going to understand their disease most likely. You can't assume that, but it's something that will likely happen. Again, and then again, a critically ill child is going to have a harder time maybe even just participating in an assent effort. Everything that's in that assent is what you're going to present to the child. Their discomforts are probably a paramount thing to be sure to stress with kids, because that is what's going to surprise them the most when you are doing something that hurts them. That doesn't minimize any other aspect of the assent form, but that's a critical piece. Sometimes, again, IRB members can be present when you do the consenting, and this statement is about. But they will give you, but again, as can anybody on the research team, the process by which we assent children and consent parents, and I'm going to say consent parents, but it's really getting parental permission. You'll see some of the language over the past 5 years, I think, has changed. We often think about consenting parents and consenting children. We're really getting the parents' permission to include their children in the research study, but it is consent, but it is sort of a permission as well. I was in a conference in the UK several years ago, and there was a very outspoken woman who felt that parents should never have a say in any research a child participated in. The child should have total say, and even down to the toddlers. So, you could almost argue that if you're a 3-year-old, should you be allowed to say whether you want a needle stick or not? It's not required. Maybe you should.
But that person doesn't have children.
I think that's true. So one of the challenges that you will face is what if a child dissents from participating and the parents really want them in? I do think have many of you consented children, been involved in that process, faced that issue of having the parents get quite upset when the child did not assent to be in the study? It is an ethical issue, and it's very difficult. It's possible, again, I'll just put this, the wrong way. It is possible in some situations that if you really are confused about this, contact the IRB. Again, they're your backup. They can tell you you're doing the right thing, or tell you maybe there's another way around it. But I'm sorry. So again, children may assent or dissent from participation. It's really important that they understand what's going to be happening. Judging their capacity to understand is sometimes the most difficult. If you don't know the child, one 10-year-old child can be quite mature, another 10-year-old child can be quite immature. So even though we set the assent age at 7, say, who knows? I mean, there's going to be great variability in each child. Sometimes that seems to me to be a bit different than adults. I mean, once people reach the age of 21, yeah, there's There is variability, I won't deny that, but for children it's much harder to measure, to gauge. So be very cognizant of even though you are assenting that child, there may be a possibility that the child is so immature that they really can't even, they're more like a 6-year-old or 5-year-old than a 7-year-old. So this is often a question that is, again, there are general guidelines for this, but it's all going to be still dependent on the risk of the study, the age of the children, the kind of condition of the child, and the type, and just all the factors we look at when we consider consenting. So what is normally said, what the regulations do say is that one parent should sign, can be required to sign excuse me. You might only need one parent to sign a consent form if it meets the criteria 1 or 2. They're in one of those 2 categories. So risk 1 level or risk 2. That's where you've got no greater than minimal risk and no greater than minimal risk with the prospect of providing benefit to that child. So again, you can have one parent sign. It's determined that the risk is adequate to allow one parent to determine whether the child should be in the protocol or in the study. But again, it's going to vary, and the IRB will help you determine whether it's 1 or 2 parents. Under 406 and 407, which is really number 3 and number 4 on our risk assessment sheet, it is encouraged that 2 parents would sign because the risk is getting greater and more people, and so it's felt that both parents should be participating in this process. We spoke earlier about reasons why you might not have 2 parents if you can't find a father. Those still would apply here. Sometimes you're not able to get both parents. So it's, anyhow, so please know and be aware of your consent form and whether it does require 1 or 2 parents. As we mentioned earlier and have already discussed, sometimes parental permission is not appropriate. And again, as Lee mentioned, it can occur depending on the disease condition and the child's age. Sometimes 13-year-olds with STDs, maybe they could be in the study without parental permission. But again, it's not going to be our call as much as giving all the information about the protocol to the IRB so they can help you make that determination. Children who are wards of the state, get clear guidance from the IRB on how to manage that. I think every state manages this a bit differently, and I honestly don't know myself what Alabama's requirements are for how the wards of the state, whether they can consent children or not. Do you all know if that's if the state has any impact on that? I mean, what our state allows? Is it
Policy about it.
Yeah. We generally have to go legal with that, and they do not like for us to enroll children who are wards of the state. I only had that instance once, and it took a lot of paperwork. There was a lot of witnesses that went on.
Doesn't each child have to have an advocate?
They do. Every child has to have a blood attendant or paraplegic guardian ad litem, somebody to oversee what's being done.
I'm just saying, this is different than a legally authorized or person. So yeah, that's a different person. That person, legally authorized representative, has the ability to consent a child. But again, we're at the stage that passing through the system.
And in one study that I had, where that was an instance, both parents were institutionalized. They were incarcerated. Mm-hmm.
Probably the child was with in other ways. And so, yeah, it's not uncommon. The key of including children in research is they are a vulnerable population. And you just need to understand the risks that they're facing and the maturation of that child. Permissions and assent are based on protocol risk management. Again, a lot of the themes I've mentioned have been repeated, but it's all about risk for these children. The greatest challenge, again, it's a blessing to have IRBs to help us work through all this, Another challenge, one of the great challenges is assessing the ability to assent. It's not clearly defined. It's going to end up being per protocol. We do have general guidelines, but it's not black and white. Ethical and practical conditions for valid assent are missing. We don't have guidelines for that. So it's really, it requires a lot of the investigative team when you're bringing a child onto a study to make sure that you are disclosing everything you are supposed to make sure that the child's assent and the parent's permission are fully informed to the level that they can understand it and need to understand it. There's, again, a little guidance on the role that children who are determined to be incapable of providing assent might play in decision-making about research participation. I think this falls under the category of children who may have some mild forms of retardation or mental incapacities. Just to say they can't understand something. You know, we don't know that they're totally unable to assent for themselves. And it will vary from child to child. I think with adults, one could argue that, well, with many adults, there's a lot of gray area, but we have the law behind us. If you're over 21, you are an adult, and unless you're designated to have some major incapacity, you are not considered vulnerable. One could argue, is that always true? And I don't know. You know, I think it's something we face more than anyone else does. Points to consider. Again, I'm not going to read through these. It's everything we've talked about. It's issues related to understanding the protocol, understanding your subject, understanding what you need to be doing when you're consenting a child. Understanding what you need to be telling your families about why, when they come into a study, why are they not just included? Because we're only including the children in when it's maybe for that particular protocol, it's less than normal. And again, assuring them of all the safety measures we have in place. I think that's one of the things that the public doesn't really understand. In our office, we do consent children for families frequently. And I think I heard the investigator who does most of the consenting, this really key is heavily involved, is that he spends a great deal of time talking about the safety issues that have been put in place, the checks and balances, the people who review the protocol, the studies that were done before. And I say all of that not to make it a coercive consenting process, but it's sort of an assurance that we're not just throwing people into research studies without any experience or without fully informing ourselves of what we're doing. And every state is going to have different requirements. Again, know if your parents are both going to need to consent. The IRB will tell you, but when you go to consent a child, make sure you get all of that. If you have any questions about whether, if you need two parent signatures and you have a question about whether you have to continue to hunt for that second parent, if you need to vet it with others, you need to talk to the IRB. They would help you determine if you need to continue the hunt for the missing father, or whether you can accept the fact that he's missing. I guess in this day and age, we've got to undo our bias that if there could be a missing mother, and the father's taking care of the child. So, your slides have a lot of detail on them from the regs. Use it as a reference. Know that the most important thing is these are vulnerable. This is a vulnerable population. It's a group of human beings who need great protection, and yet we must do research on children. There are too many drugs out there that we do not have any knowledge about whether how it is managed in a child, how it is processed in a child. We assume it's just like an adult, at least in the past, it was smaller. That's not true. Children metabolize at least up to the age of 12. They may metabolize drugs differently than adults do. So it's a whole new being, like a whole new drug when we go into children. So you hopefully will continue to see more and more research with children. So Barry, do you want to talk a little bit about...
You have said everything that I need to say, but I've been trying to think of things that you didn't say. So,
I don't have any slides. This is really going to be just adding to what Penny has said, anecdotal. Penny has asked me to share experience that I have had as a pediatric research nurse coordinator related to the issue of consenting children, which really expands my experience to dealing with the family. Again, I'm going to repeat this vulnerable population. Obviously, that's what we're dealing with, this vulnerable populations. And I kind of feel that dealing with children is like I feel when I'm dealing with pets, that they need an advocate and they need regulations. At the same time, there's a lot of issues related to family dynamics and perceptions of the healthcare delivery system that we don't understand. We're so involved in it that when we go to the doctor, the nurse, or whatever, we're probably comfortable. For a lot of people, they're not innately comfortable, and they may in fact be really distrustful. I came from an adult setting where we all wore white jackets, and mainly because you could put things in your pockets, to find out that for pediatrics, it's scary. A lot of people thought I was being really uppity, that I was wearing my white coat, and I was like, no, I just need all the pockets. But, you know, it's better if I wear something that has ducks on it. But, you know, it's the perception. It's the smell. There may be alcohol swabs, and we don't know what that smells like. It smells like the last time that they went to the doctor and hadn't had a shot, and it was really painful. And now they're in the emergency room because they can't breathe, and here's somebody presenting something to them or to their family, and they're just not sure what to make of it. Sometimes what I do when I'm approaching a family or situation is I just kind of ask them, have you ever been in a study before? Because a lot of people that we see, especially being a public health institution, have maybe been in a study before. It could have been a questionnaire. A lot of young women have been in studies through GYN, OB kind of situations. Either it's a questionnaire or it actually is, you know, a research study that involves some visits and so on. But the deal is, had they been through the consenting process? And that's kind of a clue to me. If they have, then hopefully they kind of know we're on the up and up. We're not trying to sell them something. We do have a legacy. Hopefully that's kind of going away with Tuskegee, but still the perception that I'm walking in here to use you as a guinea pig is still there. So I have to do everything I can to make them feel that is not the case. And when I'm talking about somebody's baby, and that baby can be 4 days old or 14 years old, it doesn't matter. I'm talking about a member of their family. So how are children defined for research? I found this kind of interesting. Things are so state by state. So here in Alabama, my understanding is that we define, well, the federal regulations say that there are some vulnerable populations that we need to protect with some special precautions, and Penny's going over all of those things. So who are those special populations? In Alabama, it is those persons who are under 19. In the state of New York, it's those persons who are under 18. So that has become a problem for me, developing a consent form with a study that I'm one of several sites, and what I get is a consent form that's requiring something that our state doesn't require. So you have to clarify. With our state, if that person is 18, they need a special consent. For this central unit facilitated kind of study that maybe is in several states and several countries, they don't require that. So again, you go to your local IRB. Those of you who are remote, I hope that your IRB is as responsive as ours. They have been my lifesaver. I have you guys, or have had you guys on speed dial, because I figure that if I don't know the answer, I need to find it out before I move ahead. So there are some times when assent from children isn't necessary, and Penny touched on that. And there's sometimes when children are just not capable of assenting. If you're 3 days old, you're not capable of assenting. So it's related often to age. There may be maturity. There may be issues related to psychological status. There may be someone who's 15 but is not able to provide consent because of incapacity with psychological things. So there are also issues where we don't need to ask for the assent of the child, and that is when the child can directly benefit from this treatment or procedure, and that it's only available in this trial. In that kind of situation, the parent consent goes. Unlike informed consent in adults, the assent process for children is not required by law. It is strongly recommended, and I think to be able to go forth with a study, your IRB would intervene and say, this is what we require, but it is not a legal thing. Am I right with that? It's a technicality. It's not, it's not required, but I'm not going to be able to do my study unless my IRB approves it. So it's that kind of thing. But my point sort of is, it's just not clearly defined, as Penny said. To repeat our local IRB, for dealing with consenting with children, parental permission is always required. Actual consent can be waived if you're under 6, but a simple review of the protocol is recommended. Imagine that you're that kid. I think it engages you. It makes you feel like you matter, and I think you would be more compliant if somebody is explaining to you what's going to happen, should you choose to participate in whatever it happens to be. It could be something that doesn't involve anything painful. It could be a questionnaire. It could be, we're trying to determine the safety in crossing streets from the playground, but it's good if they understand what they're involved in. They've got a very short attention span, so it doesn't have to be a very long explanation, but just so they know that's what's going to be happening. Anecdotes. Penny has mentioned several that we talked about, and like I said, I used to work with adults, so my first thing that happened to me with a pediatric study, I was faced with the parent was 17. And I'm thinking, how can she give me consent? I realized, of course she can. She's a parent. That decision was made. She is a parent, and she can give me consent for her child. If she wants to be in the study, her parent, if that's appropriate. But in this situation, it was just something I'd never thought about before. Here's a child giving consent for a child. I got over it. When assenting, did I skip? I think I skipped something, and that was just, no, I didn't. The ages that the IRB here recommends assent. And again, it's not written in stone, but between 7 and 12, an assent form is recommended. And I included one in the handout because I just think it's so adorable. I wish this was the way it was explained for adults. It was just like, here are some things we want you to know about research studies. Why am I being asked to be a part of this? What is it about? What's going to happen and when? Will it hurt? How much? I just think, as a grown-up, what else should I know about it? What are the good things that might happen? What if I don't want to be a part of the study? Is anything bad going to happen? I just think that as an adult, I wish it was written simply like that for me as well. But this is just an example of what we use with kids. So that's the kind of assenting that is done for a 7 to 12-year-old. as Penny mentioned, we go through, it's very simple. The parent, usually the mom, in my cases, has already signed, yes, we're going to do this study. Did I mention that there's a $20 gift card, a $10 gift card, $50? You know, of course I mentioned it. Of course mom wants that. The kid has kind of listened and explained what we're going to do. When it comes time to doing what we're going to do, one particular study, it was nasal swabs for a flu study. I don't know about you guys, but I've had a nasal swab and it was really very unpleasant. This was 2 of them. So as completely as I could, I described how I was going to do it and told them, which was a lie, but told them that I'm a grandma. I'm going to treat you like you're my grandchild. I'm going to be very gentle. After you do the first one, the deal is up. They know what's coming. And sometimes they can be a big boy or girl, but I had a kid who started throwing a tantrum, got into the corner, got up on the exam table, Mom started threatening the kid, you are going to do this, damn it, you know, and it shocked me. All of a sudden, the professional nurse was gone, and the protective woman was there, and I don't think I acted, in 2020 hindsight, I know what I would have done. What I did was try to calm the kid down and say, you don't have to do this if you don't want to. That family doesn't believe that. When you say you're going to do something, you do it. Blankety blank. And that is true usually. You know, you say you're going to do the dishes, do them. You say you're going to help your sister, do it. It was a very uncomfortable situation. The mom was yelling at me. You know, they wanted the money, and the kid was feeling like the kid had failed. It just got to be one of those situations where the kid was like that. And not that this makes a difference, but it was, the gender was male. And for you males out there, he was 11, and I know he wanted to be a man, a little man, but he was a child. And this brings tears to me right now because I didn't know what to do. I couldn't speed dial the IRB and say, what do I do now? But I know now, the saving grace for us is that we have documents. Now, why is it happening to me now? But blame it on the document. And the thing is, the document says you have the right to say no. That's what I didn't do. That's what I learned from that. All right, moving on to something else quickly, and that is are we running over? Okay. The extension, what I have found with children is the extension of the consenting process when they are inpatients. And that is, you consent to the parent, and it may be a situation where either you need assent or not, depending on the age of the child. But you're coming into a situation where you're on the floor of a hospital or in an outpatient clinic, and you haven't shared this study or this information with your auxiliary people or with the staff. And then what they communicate to your properly assented, consented, all forms are signed, everybody's got a copy, you document it. You come in to do the study procedure, and the family is saying, whoa, you're not using my baby for a guinea pig. They said that you don't even know what that drug is. You don't even know what it does. You've gone over the risks. You've gone over this. Your PI was more compassionate than Mother Teresa has been in there. You've gone over all that. But that consenting, and maybe it's not only with children, it could be adults too, but we have to realize that we know what we're doing. But those around us have to be on board too. They have to know that what we are doing with this vulnerable population is we are dotting our I's and crossing our T's, dotting our I's, that we are not doing something unsafe. One other example, then I'll let everybody go when you're hungry, and that was the issue of reconsenting when there's been an updated consent form. updated consent form, and so the patients that are coming in subsequent to this, when they come in for their next visit, they need to update the consent form. Had two adorable twins who were in a study, and they were in the study from birth. This was going to be the last visit. They were going to be two-year-olds. Mom, who was 18, lived with grandma. Mom took care of one, grandma took care of the other. It worked out great. They had come in for all these visits, and there were numerous visits until the 1-year part, and it got spread out. After 1 year, then we didn't see until they were 2. It was always kind of freaky. You're like, oh my God, they're just toddling around. Mom couldn't come in. By this time, Mom had gotten a job. So I called and said, Grandma said, well, is it okay if I bring him in? I'm like, yeah, there's just a little detail. It's a form that you have to sign, and really needs to be your daughter. And, we had a relationship with these people. We've been seeing them weekly for months. Anyway, so I said, it's all right. Come on in. I just thought, I'll just document this to the max. I'll just document all this kind of stuff. Not good enough. The informed consent was signed by Grandma, who was not their legal guardian. And I had to fill out all sorts of forms with the IRB. My monitor was having a fit. And I had documented it. It was not like I'd done something terrible. But I realized there are reasons for this. We recommended to this grandma, who was going to be taking these twins for their medical appointments, and they had lots of issues. They were going to be coming back. See, this is a good time for you to maybe go and become a legal guardian so that you can, in fact, do this. The end. That's all I have. Thank you.
So how do you prove that? How does that grandmother come back? I mean, do you ask for proof from every parent? I need a birth certificate from.
I just asked them.
How do you? But how?
I trust them.
Like your children that you were talking about in the emergency department, you felt like wanted the money. Did you take that? I mean, yeah, this is my mom. I mean, does that mom have to prove that that's her child?
That's a really good question. We don't ask for birth certificates.
No.
I mean, that's what you would almost need to have proof, and we don't.
I usually will just say, who's the mom? Or I will walk in. Who's the mom? Because sometimes it's several adults.
Right.
When you don't know who's auntie, who's grandma, who's mom, who's sister, who's neighbor, or whatever. And so I usually walk in, so who's mom? Who's mom here? Oh, mom's not here. Well, is there a legal guardian? No, we're the neighbor. Oh, okay. All righty. Well, nurse will be in with you in just a minute. So I do it that way.
Yeah. So have you ever?
I don't know.
That's always a good question. I mean, how do we know?
And that's a one-time visit only. This is not supposed to be an extended trial. That I will take that for an answer. So
we don't have specific guidelines for how to prove parentage.
Mm-hmm.
We do. It is a great question. We remind you guys that you need to be checking it some way or another. But as far as specific ways that we recommend or require, we don't have that.
Doesn't the consent to treat form, and I assume the IOB consent to do the research form, attest that they are the parent and or legal guardian?
It requires a signature on a line that says parent. The line will say parent, and they have to sign above that.
I wonder if that.
The IRB form does not say I attest that I am the parent
I
or
wonder
legal
if
guardian.
that verbiage might help.
I've had a situation that was a longer study, and it was for like 6 had a baby, and she was going to be in the study, so she came with her sister, who she said was her legal guardian. In actuality, she wasn't, and it was only with a new informed consent change I found out. But there is a document. There is a legal document.
We use our social workers, our big help, because we'll get a lot of
complicated family situations.
Mhm.
And for various reasons, the social worker needs to know that. And so a lot of times, when our kids are newly diagnosed, the social worker will go in prior to any kind of study type task. And so if there is something that is different and unique about that family, they'll point it out ahead of time.
That's really good.
Thank you all for coming out on this wet day. Stay dry when you're back.
So what ultimately happened?
Yeah, I mean, also,
Calm down and get
it's so much better to hear before the situation is, you know, right there.
Sorry, I didn't know. I can't believe it. But they don't, that was what I did. That's what I did. They sit down and discuss it. Even this little kind of, I've been here 6 months. I said, why would I be here? You know, we recorded that, right? I mean, well, I mean, inviting them officially, but basically, right, yeah, but it's not going to go, okay, we're not, you know. Anyway, you're right, you got me right. We'll get there. Yeah, we will. Thanks for your take. Good. Thank you. Thank you all.
Well, I mean, they weren't selected, but yeah, I had